Good afternoon, everyone. We are delighted that you can join us. My name is Lydia Dugdale. I'm the director of the Center for Clinical Medical Ethics at Columbia University, and it is my great joy to co-host this afternoon's event with my friend and colleague, Dr. Barbara Rothschild. So I'm going to turn it over to you, Barbara, to introduce yourself and our speaker today. Thank you.
Thank you, Lydia. It is one of my favorite parts of my job that we get to do these talks. Lydia and I are often trying to think about topics in medical ethics that aren't getting taught perhaps adequately in the medical schools or not talked about enough in our colleague circles. And in my class, I teach here at Columbia University, clinical ethics in the Master's of Bioethics program. And in my class, which is a clinical ethics class, we often run into cases where the patient maybe have a weight problem or is overweight. And the bias that comes out in our discussion was very clear. And over time, I got to think, anytime we see bias in medicine, there's probably something else under there, more to uncover, more to talk about, and a way to provide better health care to those patients. And so as I started reading, I came across our guest speaker, Dr. Rebecca Poole's work, and I would love to introduce her, but it really helped open my eyes into weight stigma and the effect weight stigma has on healthcare. And I think she'll be able to help us all do a little internal searching and how we feel about and weight stigma and bias. So if I could just introduce her now. Dr. Rebecca Poole is Deputy Director for the Rudd Center for Food Policy and Obesity and Professor in the Department of Human Development and Family Studies at University of Connecticut. She's responsible for identifying and coordinating research and policy efforts aimed at reducing weight bias. She earned her PhD in clinical psychology from Yale. She's conducted research on weight bias for 15 years and has published numerous studies on weight-based bullying in youth, weight bias in healthcare and the media, interventions to reduce weight bias, and the impact of weight stigma on emotional and physical health. She's testified in state legislative hearings on weight bias, routinely provides expertise to state and national health organizations, and has developed evidence-based training programs to reduce weight bias that have been implemented in medical facilities across the country. And I know she's also part of the joint consensus statement on reducing weight bias that was published in 2020. She's a leading national expert in this field, and we are incredibly fortunate to have her with us today. And I have to say, I've been looking forward to this presentation for a while. So we're thrilled. We'll luckily have time for questions. So please put your questions in the chat as we go. And Dr. Poole, I'll hand it over to you.
Great, thank you. Well, hello everyone, and thank you for the introduction. It's a pleasure for me to be speaking to you today about our research on weight stigma and how it's relevant to health and patient care and health communication more broadly. So in the time I have today, I'd like to cover several primary objectives. First, talking briefly about the nature and extent of weight stigma, and then providing a summary of research evidence about the consequences of weight stigma, both for psychological well-being and physical health, and also looking at the ways in which weight stigma interferes with effective patient care and strategies that can be implemented to reduce weight bias in clinical practice and health communication. So let me first begin by saying that when I'm referring to weight stigma, I'm referring to societal devaluation of people because of their higher body weight or larger body size. And at the foundation of weight stigma are strongly ingrained stereotypes that people who have higher body weight are lazy, lacking in willpower and discipline, unmotivated to improve their health, and personally to blame for their weight. And these societal stereotypes are pervasive, and they set the stage for different forms of prejudice and unfair treatment and discrimination. And what has become very clear in the research that we and many others have done over the past couple of decades is that weight stigma is present in almost every life domain, ranging from close interpersonal relationships to educational settings, to the workplace, to healthcare, and also in the broader mass media. And today I'm not going to be discussing all of these different social settings of stigma, but I do think it's important to acknowledge that one of the reasons why people are vulnerable and why we observe such negative health consequences of weight stigma is that it's essentially impossible to escape this form of stigma in a person's life. There's just really no place where a person is protected from these experiences. And it's also important to acknowledge that the experience of weight stigma is not unique to a certain time period in one's life, that it is present and can persist throughout the lifespan. So we know from research that weight stereotypes are present as early as preschool age, and they continue through late adulthood. So for individuals who have a higher weight early on in their life, like a child or adolescent, confronting weight stigma can be a lifelong struggle, which really begins in the form of teasing and bullying, but can expand over time to include unfair treatment and discrimination. And so this lifespan context is also important to consider when we start to think about the nature and the health consequences that occur from weight stigma. So before I jump into a discussion of the health consequences of weight stigma, I want to first comment on the prevalence of this problem, both in adults and in youth. So across national studies in the US, pooled prevalence estimates on weight discrimination for adults who have a higher weight, like obesity, range from about 19 to 40%, with the highest rates of weight discrimination among those with the highest BMI. We typically see higher rates of discrimination in women compared to men. And in a series of national studies that we've conducted, we see pretty consistently that about 40% of American adults report that they've experienced some form of weight stigma, whether it's in the form of teasing or mistreatment or discrimination. And I should note that we tend to see similar rates of weight stigma across different groups with respect to race and ethnicity as well. And what this means is that many people are living with multiple stigmatized identities because of both body weight and race. And we see this high prevalence of weight stigma and discrimination across different countries. So my team recently completed a multinational study examining experiences of weight stigma in about 14,000 adults across 6 different countries. And this was a weight management sample of adults, so members of WW, formerly Weight Watchers, trying to manage their weight. And our data show high percentages of adults across these countries reporting that they were teased, mistreated, or discriminated against because of their weight. And interestingly, we found very few and often no differences in people's reported experiences of weight stigma between these different countries, despite the fact that prevalence rates of obesity do actually differ across these countries. Now, for many people, experiences of weight stigma begin in youth. And in some of our recent research with adults actively trying to manage their weight, almost half reported that they first experienced weight stigma during childhood or adolescence. We also found that people reported the frequency of these experiences and distress related to weight stigma as being higher during childhood and adolescence compared to other later time periods in their life. And when we look at prevalence rates of weight-based bullying in diverse samples of youth with respect to body weight and race ethnicity, we see about a quarter to almost a half of girls are reporting that they're being bullied about their weight, and at least 20% to about a third of boys are. Now, the studies that I've highlighted here primarily refer to adolescents. And in the first row of this table, which involved a very large sample of ethnically diverse adolescents, these youth were more likely to be bullied for their weight or their physical appearance than for their race, ethnicity, sexual orientation, or disability. So it's peer-based teasing and bullying about weight that is really most common during this early time period. But what is particularly concerning about weight stigma in youth is that parents and family members are also common sources of weight-based teasing. And I've highlighted a handful of our studies here where we've asked adolescents and adults about the interpersonal sources of weight stigma in their lives. And family members are often one of the most common sources reported. So you can see how high these percentages are here of people who say that their parents or family members have stigmatized them about their weight. The lowest is more than a third, and the highest is almost 3/4. And then beyond family and peers, weight stigma is also a problem in the healthcare setting. So several decades of research have documented evidence of weight stigma in the medical and clinical care setting. And this often occurs as negative and stereotypical attitudes that are expressed by healthcare providers toward patients with obesity. And the kinds of stereotypes that have been documented in providers include the same views that we see in the general population. So that patients who have obesity are non-compliant with treatment or lazy, lacking in self-control, sloppy, unsuccessful, unintelligent, dishonest. These attitudes have been documented by a range of healthcare provider specialties, including physicians, nurses, dietitians, mental health professionals, and also by students who are training in these professional health disciplines. And these biases appear to be present long before healthcare professionals enter clinical practice. And so this slide shows a study that we did led by my colleague Sean Phelan with over 5,800 first-year medical students from 49 medical schools in the US. And the majority of students here expressed both explicit and implicit weight bias, especially among students who were male, white, or Hispanic, and with a lower BMI. And so this tells us that we need to be addressing this issue early on in medical training. And it does appear that patients are aware of these biased attitudes in their healthcare providers. So as an example from our own research, I summarized 3 studies here with fairly large samples of adults who have higher weight. And when we ask if they've ever experienced weight stigma from a healthcare professional, you can see how high these percentages are, particularly for experiencing weight stigma from doctors, which was reported by more than 2/3 of people, but also from other healthcare professionals as well. So given these high rates of stigma, these different interpersonal sources of stigma, how does this impact people's health? So a key consideration here is the emotional distress that weight stigma creates for people who experience it. So we know from substantial research evidence that weight stigma induces a range of psychological consequences, including higher levels of depressive symptoms, anxiety, lower self-esteem, poor body image, increased levels of substance use, and even suicidality. And higher levels of suicidality are reported by those with high BMI who have experienced stigma or bullying compared to their same weight peers who have not experienced that stigma. And the psychological distress of weight stigma has been documented in both adults and in children, in both community samples and weight loss treatment samples. And importantly, these research findings persist after accounting for BMI. Why that's important is that it tells us that it's not body weight or obesity per se that is leading to this psychological distress, but rather the experience of being stigmatized for one's weight. The emotional toll that weight stigma has on mental health is very damaging, especially when we consider that weight stigma can come from close family members and friends. And so those close relationships are not necessarily available for emotional support. And as we live in societies that do little to challenge weight stigma, there aren't clear ways for people to seek support if they've experienced stigma, and that can often worsen the distress. Now, a particularly striking finding that has emerged in prospective research is that experiencing weight stigma predicts weight gain and obesity over time. And these findings persist after accounting for baseline body weight and sociodemographic factors. And interestingly, other forms of discrimination related to race or gender-based discrimination don't seem to have these same effects on weight gain. It appears to be more unique to weight-based discrimination. And this evidence has helped us to understand weight stigma not only as a psychosocial consequence of obesity or having a higher weight, but as a psychosocial contributor to obesity as well. So a key question here is, why is weight stigma contributing to weight gain, and what are the mechanisms? So first, it's important to think about the ways in which the psychosocial stress of weight stigma contributes to weight gain and obesity. And psychological distress itself is a negative outcome of weight stigma, but it can also reinforce unhealthy coping strategies in response to weight stigma. And it can lead to self-blame and internalization of weight stigma, both of which can in turn lead to unhealthy eating behaviors that worsen health and can contribute to weight gain. So I'd like to share with you some of our recent studies that highlight these links between stigma and maladaptive eating behaviors and other health consequences, and how people's coping strategies to deal with stigma and their internalization of the stigma play an important role here. So a substantial amount of evidence shows that weight stigma is associated with maladaptive eating behaviors. And in particular, binge eating has emerged as a very common correlate of weight stigma, and not just in adults, but also in children and adolescents. So for example, adolescents who experience weight stigma have an 80% greater likelihood of severe binge eating. We also see links with weight stigma and increased food consumption, unhealthy weight control behaviors, disordered eating patterns, emotional overeating. So essentially, those who experience weight stigma have a higher prevalence and a higher frequency of these unhealthy eating patterns. And these links are present, again, both in children and adults, both community samples, both clinical samples, and some of this research also controls for body mass index. So one of the reasons why we observe maladaptive eating behaviors is that people may cope with the emotional distress of weight stigma by turning to food. So about 15 years ago, we began to study this issue in a sample of 2,400 women in a self-help weight loss organization. And we asked them how they coped with weight stigma that they experienced. And women reported using all sorts of different coping strategies. Some were positive, some were negative. But a striking finding was that almost 80% reported that they tend to turn to food as a coping mechanism, and that eating temporarily relieved their distress. And we know from the psychology literature that stigma is a stressor and that eating is a common coping strategy in response to stress. And that certainly makes sense in the context of these weight stigma findings. And we've continued to see similar findings emerge time after time in our studies since then. So this slide shows a more recent example of a national community sample of about 2,400 adults. And we found that the more weight stigma that people reported experiencing, the more that they were coping with this stigma by engaging in disordered eating behaviors, increasing their eating and food intake, and avoiding physical activity. And we've observed some of these links between weight stigma and unhealthy coping responses during the COVID pandemic as well. So we've published a study in 2020 from Project EAT, which is a longitudinal cohort study led by Diane Newmark-Steiner at the University of Minnesota. And it followed almost 2,000 adolescents for more than 15 years through their mid-30s. And data from this cohort were collected in the spring and summer of 2020 to look at people's health behaviors during the pandemic. And so for this particular study, what we found is that pre-pandemic experiences of weight stigma that adults were experiencing and reporting back in 2018 were predicting worse eating and emotional distress during the COVID outbreak compared to those who had not experienced weight stigma before the pandemic. And specifically, those who reported that weight stigma before had a much higher level of using food and eating as a coping strategy for dealing with stress. And they were binge eating much more frequently during the pandemic. And so this also tells us that under times of pandemic, when there's considerable stress and upheaval, that these patterns are persisting, which obviously has concerning health implications. So we do see that weight teasing in adolescents can have really long-term implications for both eating behaviors and weight gain over time. So as an example, in our longitudinal analyses with Project EAT, we found that both girls and boys who were teased about their weight in adolescence were more than twice as likely to have obesity and more likely to be eating to cope with emotions 15 years later in their mid-30s compared to their peers who were not teased about weight. And these analyses controlled for baseline weight as well as sociodemographics. So we're seeing that weight stigma has implications for future eating behaviors and weight gain in adulthood, even when these experiences happen early in adolescence. Now, in addition to maladaptive eating behaviors, we also see from evidence that when people experience weight stigma, they're less likely to engage in physical activity and exercise. And often because physical activity settings are places where they feel vulnerable to being stigmatized or shamed about their weight. And so they cope with those experiences by avoiding them. And in adults, experiencing weight stigma induces negative feelings about engaging in physical activity and lower intentions to do so, as well as avoidance of exercise. And in children, we see the same pattern. So very high percentages report being teased about their weight during physical activities at school, which is not surprising. And that can lead kids to really avoid physical activity classes or sports in order to escape the distress of those teasing experiences. And it really reduces their engagement and their enjoyment in physical activity. Now, evidence also shows that the psychosocial stress of weight stigma may also have negative effects on physiological stress, which has implications for body weight. So people who experience weight stigma have elevated stress responses, including elevated levels of C-reactive protein, high cortisol, high blood pressure, higher A1C levels. And importantly, these findings persist independent of BMI, which again tells us that it's really the experience of weight stigma, not body weight per se, that is increasing vulnerability to these physiological responses. So when people react to weight stigma with elevated psychosocial distress, this can in turn have a negative effect on their physiological stress responses. Now, besides adverse coping responses to stigma, another important way that weight stigma can lead to things like poor eating and poor health is how people interpret stigmatizing situations through a process that's called internalization of weight bias. So, what can happen when people experience weight stigma is that the negative societal judgments that they face can become an internalized process of negative self judgment and self blame. So, internalizing stigma happens when people are aware of weight based stereotypes, they apply those beliefs to themselves, and they engage in self directed stigma and personal blame. Now, internalized weight bias is pretty common in the general population. So, national studies have found that about 1 in 5 people have fairly high levels of internalized weight bias, and over half of people with obesity are blaming themselves and engaging in self stigma. This is especially likely among women with high BMI who are trying to lose weight. Now, why this matters for health is because we're seeing from research that internalizing this weight bias can have the same negative consequences for eating behaviors and weight related health as experiencing weight stigma. And in fact, what we're starting to see in studies is that internalized stigma predicts poor health more than the experience of stigma or unfair treatment itself. And these links, again, are remaining after accounting for people's body size and also how much stigma they've actually experienced. So we've seen in a number of our own studies that internalization has some concerning implications for weight management. And I've highlighted an example here, which is a study that we conducted with adults who had lost at least 10% of their weight in the past year. Some of them had maintained that weight loss while others had regained it. And we looked to see what role weight stigma might play in these outcomes. And we found that while typical behaviors that are linked with sustained weight loss, like dietary monitoring and self-weighing, were not significant for these groups, there was unique predictive value of weight stigma, and specifically internalized stigma, when it came to who maintained versus regained that weight. And specifically, we found that as levels of internalized weight stigma increased, the odds of maintaining weight loss decreased by almost 30%. And this evidence suggests that the internalization and self-blame that results from stigma can be interfering with people's efforts to really maintain their weight loss, regardless of how much weight stigma they've actually experienced. Another example of this from our work is a large US study that we did with adults engaged in weight management who were enrolled in WW. And we found that internalized weight stigma, but not experiences of weight stigma, were associated with lower odds of weight loss, higher odds of weight gain, and worse weight management behaviors. And these findings persisted after we controlled for participants' BMI and sociodemographic characteristics. And so this shows us that internalized weight stigma is playing a role in potentially creating barriers. Now, if we return to the issue of how people cope with weight stigma, we're starting to see internalized weight bias aligning more with unhealthy coping strategies in response to weight stigma. So we have found that among people engaged in weight management, that those who internalize weight stigma use more maladaptive coping strategies in response to experiences of weight stigma, like engaging in disordered eating and avoiding exercise. And they also use fewer adaptive coping strategies like seeking social support or engaging in positive weight talk. And in summary, what all this evidence is showing us is the ways that weight stigma can ultimately contribute to weight gain and obesity. So the psychosocial distress of experiencing weight stigma can lead to maladaptive coping strategies to deal with this distress, as well as internalization of stigma. And both of those can reinforce unhealthy eating behaviors and other risk factors which can contribute to weight gain. And this ultimately creates a harmful cycle, because increased weight gain makes a person more vulnerable to experiences of weight stigma, which sets this pathway in motion again. And so in this sense, it's helpful to think about weight stigma as both a psychosocial contributor to weight gain, but also a psychosocial consequence as well. And finally, beyond all of the health consequences I've already mentioned, it's important to highlight that weight stigma also impacts healthcare and experiences of patient care. So research examining provider practices shows that compared to providing care to thinner patients, that when it comes to patients with higher weight, providers demonstrate less time in their appointments, less discussion with patients with higher weight. They admit that they don't intervene as much as they think they should. They report having less respect for patients with higher weight. And then when we look at research of patient perspectives, we see that they are well aware of provider biases towards them. And as a result, they report having lower trust in their providers. They are reluctant to talk about their weight. They perceive a lack of empathy and believe that they won't be taken seriously. They report that their weight is really blamed for unrelated medical problems. They're more likely to switch doctors, and they're more likely to avoid healthcare. And this is something that we have seen in our research as well. But what we're starting to see is that healthcare avoidance and poor quality of care may have important links with internalization of weight bias. So in our recent multinational study that I've mentioned a couple of times, we found that compared to people who had low levels of internalized weight bias, that those with higher levels of internalization were much more likely to avoid healthcare. They obtained less frequent routine checkups. They perceived that their doctors were negatively judging them about their weight, that their doctor had less respect for them, didn't listen to their needs, and overall perceived the quality of their healthcare to be lower. And this pattern was consistent across each of the countries that we studied. And I should note that BMI was not associated with any of these healthcare experiences. So when we consider all of these links between weight stigma and poor health and healthcare, it's clear the ways in which stigma reduces quality of life. It impacts many different aspects of health, ranging from psychological distress to disordered eating behaviors to physical activity and physiological stress and weight gain and quality of care. So what do we do as healthcare professionals and clinicians to address this issue in clinical care? The framework for the strategies that I'm going to talk about today come from a policy statement that I co-authored that was published by the American Academy of Pediatrics a few years ago. And it was the first statement that the American Academy of Pediatrics had put out on weight stigma. And we made a number of clinical practice recommendations for ways to address this issue. Now, even though these strategies were talked about in the context of pediatric care, they actually apply to all patient care for people of all ages. And these include things like increasing awareness of weight bias, giving careful consideration to language and weight communication, making sure that weight stigma is on your radar as part of behavior change counseling, and really taking steps to reduce and avoid weight stigma in the clinical care environment. So we need to start with our own personal attitudes and assumptions about body weight. We all make assumptions, and these can unintentionally reduce the quality of interactions with patients. One way of becoming more aware of our automatic biases about weight is to actually take the implicit associations test, the IAT, online, which is available at the Harvard Project Implicit website. There is an IAT that is specific to body weight, and this can be a helpful exercise to really reflect on the automatic associations that we make when we think about people of different body sizes. And then on a general level, we need to think critically about what those assumptions are and to challenge the assumptions that we have and examine how do we interact with people and patients of different body sizes. So asking yourself, how do you feel when interacting with patients of different body sizes? How do your views about weight affect your things like your body language or your facial expressions or your comments? And as part of increasing our awareness, we also need to increase our understanding of the complex etiology of body weight regulation and obesity. So a number of studies indicate that when people attribute the causes of obesity to personal factors like lack of discipline or willpower, this not surprisingly increases weight stigma. But when people are made to be more aware of the complex causes of obesity, to include additional factors beyond personal control, like the environment or genetics, we see that stigma is reduced. And we know that obesity is very complex, it's very multifaceted, and personal behaviors are only one factor. And this is something that we need to acknowledge as healthcare professionals, both to ourselves, but also to our patients. Because what we see is when patients become aware of the more complex contributors that are involved in body weight regulation, not only does it reduce their self-blame, but it actually increases their self-efficacy for making health behavior changes. So the second and highly important strategy to address weight stigma in clinical practice is how we communicate about body weight. And this is where I'm going to focus more discussion on. So we need to think carefully about whether the language that we use, even if it's unintentional or indirect, is contributing to bias or blame. And this means considering the moral tone of the words that we use, using language that is supportive and empowering to patients. Providers sometimes feel unsure about how to talk about body weight with patients and how to do that in a way that is supportive and respectful. So I'm going to just unpack this a little bit more. So I initially became interested in this topic as a research area with communication about a decade ago when A British news article generated international media attention back in 2010. The article was about comments that the British public health minister had made to doctors in the UK to encourage patient weight loss. And the health minister said, quote, "Doctors and healthcare workers are too worried about using the term fat, but doing so will motivate people to take personal responsibility for their lifestyles. Calling them obese does not provide sufficient motivation. Just call them fat. Plain speaking, doctors will jolt people into losing weight." So this news article certainly caught my attention, and it served as an incentive to do some research to look at what are people's preferences about the kind of language that their healthcare providers are using to talk about their weight. And we started off with 2 studies, one with adults and one with parents in the US. And we gave people a list of about 15 different words that can be used to refer to someone with higher weight. And we asked people to imagine a scenario in which they were or either imagined or were 50 pounds above what they thought should be their healthy weight, and to indicate how they would feel if a doctor used various words to refer to their weight. And for each word, we asked them how stigmatizing or blaming the word was, how motivating it was to get them to want to lose weight. And similarly, we provided parents with a list of words commonly used to refer to their child's weight. And for each of those words, we asked them to indicate how stigmatizing or blaming they felt it was, and how motivating or unmotivating it would be for encouraging their child to lose weight. So what you can see here, hopefully the formatting is not as off for you as it is on my slide, is that words that were viewed to be the most stigmatizing and blaming were words like fat and obese and morbidly obese, whereas words that were viewed to be least stigmatizing and blaming were neutral words like weight or unhealthy weight or even high BMI. And we also asked people in this study how they would react if a doctor used stigmatizing language to refer to their weight. And not only did high percentages indicate that this would be upsetting to them, but about 20% of adults, about a third of parents, said they would switch doctors if this happened to them. And about 20% of adults and a quarter of parents would actually avoid future medical appointments for themselves or for their child. So we can start to see how this has implications for healthcare utilization as well. And since then, more research has examined this issue, and we see the same pattern of findings in studies with samples of people who have higher weight who are trying to lose weight. There's a consistent and clear preference for neutral words when it comes to talking about body weight. So words like unhealthy weight or high BMI, but a strong dislike of words like fat or obese. Now, although we are seeing consistent preference for neutral words, one important thing to note here is that word preferences can differ a lot according to factors like a person's gender, race or ethnicity, their BMI. There is quite a lot of variation in people's word preferences. And so it's helpful to remember that body weight is an emotionally charged issue for a lot of people, and the words that they feel most comfortable with in describing their weight status or body size aren't always the same. And so this highlights that as healthcare professionals, we need to avoid making assumptions about what language to use when we're having discussions about weight with patients. And we need to acknowledge that people have diverse views about this. So what we typically recommend is when initiating a conversation as a way to respect that diversity and individual variation is to ask a patient, could we talk about your weight today, which is using a neutral word, and then to acknowledge that people have different preferences for language, different comfort levels for having these conversations. So following up by asking the patient, what words would you feel most comfortable using as we have this conversation? And then using terminology that the patient feels most comfortable with can really promote a more supportive and more productive dialogue. Now, another consideration in language that is really being promoted in the context of obesity care is the use of people-first language. And this is the use of really that avoids labeling people by their condition or disease, and it's been adopted with many health conditions and illnesses. So rather than referring to someone as an obese woman, people-first language would say a woman who has obesity or a woman with obesity. This is actually becoming a broadly accepted standard, not only in the medical community, but also by professional health organizations, by obesity research journals. And it's another consideration when communicating with other clinicians or medical professionals about patients with higher weight. Now, this is all to say that words matter and that clinicians, need to carefully consider word choice to really facilitate conversations about weight-related health without reinforcing stigma. We're not currently at a place where there is a universally acceptable word or phrase to describe higher weight that everyone is comfortable with. And in fact, right now, we're kind of at a place where people have very strong and polarized views about this. So with this in mind, it's helpful to, I think, default to neutral terminology, to avoid making assumptions, to really acknowledge the diversity of preferences that exist, and to really try to use people's preferred words when you're talking with them. If you have more questions about weight-related language, I can point you to a recent systematic review on this topic that was published in 2020. I was getting asked about language all the time and really wanted to be on top of the literature. And so I conducted this review, and it essentially summarizes what we know from a pretty scattered literature on word preferences among adults and adolescents in the context of healthcare interactions. What this review also highlights, though, is that there's a lot we still don't know about language when it comes to weight. So, for example, much more work needs to be done with more racially and ethnically diverse samples. Now, beyond the specific words that we use to refer to weight, there's also more that we need to consider when we think about how we communicate about weight-related health. How we communicate about things like eating habits, physical activity, weight-related health can also be unintentionally stigmatizing. So it's important to look carefully at the kinds of words that we use in communication about eating habits and physical activity, because they can reinforce stereotypes and they can reinforce shame. So for example, talking to patients about making excuses or resisting temptations in their diet are phrases that can provoke more self-defeating responses from people. So instead of talking about excuses, you can talk about strategies to minimize triggers. Instead of talking about discipline or having more self-control, you can talk about ways to practice healthy habits. Instead of talking about cheating on one's diet, you can talk about situations that create challenges or difficulties in staying on track. Instead of resisting temptations, let's talk about ways to cope with emotions that interfere with eating. And instead of telling people not to overindulge, let's talk about ways to feel satisfied and not deprived. And so these are relevant aspects of language to be thinking about in one's clinical practice setting. Now, we also need to think about how we communicate with patients in the context of being weighed, which is often a very anxiety-provoking experience for patients who have higher weight. And in fact, research shows that women in particular avoid healthcare because of the shame and embarrassment of being weighed at their medical appointment. Facing the scale can be such a negative experience that it becomes a reason for patients to avoid seeking care. So it's important that we use sensitivity in those procedures. And I think first, before talking to a patient about weight, we want providers to really review the patient's chart for the weight history, noting any changes in weight between visits and determining whether the patient actually needs to be weighed at the appointment. The answer might be yes, but there are often times where weighing is actually not necessary. And when approaching a patient who needs to be weighed, it's recommended to first ask the patient's permission to be weighed, and then, if they consent, to offer them the option of facing away from the scale and not seeing their results. And we want to make sure that the scale itself is located in a private office area where the patient doesn't have to worry about others walking by. And the patient's weight should be recorded silently without comment. And attention to these kinds of details of the weighing procedure can make it at least a less negative experience for patients. So moving beyond the patient encounter, I'd also like to spend a few minutes talking about implications of the language that gets used in broader communication and public health messaging about body weight. So over the past couple of decades, there have been hundreds of public health campaigns targeting obesity in the US, but very little work assessing whether the content is stigmatizing and how people react to the messages being disseminated. So we've conducted several national studies in which we randomly assigned adults to view several different campaigns and to share their reactions to them. So we used a subset of 30 campaigns that had been broadly disseminated to address things like reducing consumption of sugary beverages, increasing fruits and vegetables. We also included campaigns that had been publicly criticized for being stigmatizing. And we had participants share their emotional reactions, positive or negative, to every campaign that they looked at, their perceptions of whether it was stigmatizing, and whether the campaign messages motivated them to improve their health behavior. And essentially, we found that when the campaigns were viewed to be stigmatizing or shaming, people about their weight, that people felt much less motivated to improve their lifestyle behaviors, and they had lower self-confidence and intention to do so. But campaigns that were more respectful in their messaging and didn't contain stigma were the most motivating, especially if they focused on health behaviors rather than on obesity or weight. And in fact, when we looked at the campaigns that induced the highest motivation and intention for health behavior change, these were campaigns that made no mention at all of either body weight or obesity. And so this does raise an important question of whether weight-related health communication needs to mention weight in order for it to be effective, and suggests that focusing on health behaviors that people of all body sizes can engage in may be a more productive and less stigmatizing path to take. Now, something else that this research highlighted for us is that it's not just what we say about weight or obesity that promotes weight stigma, it's also the images that we see. And so we've broadened our studies further to look at how weight stigma is visualized in the media. And these are the kinds of stigmatizing images that really permeate the media, whether it's news media or entertainment media or social media. And we've done research to see what kind of impact stigmatizing messages can have on public attitudes. And the images that you see here portray the same man and woman on each side, but on the left, they're depicted in stereotypical ways eating junk food on the couch, and on the right, they are portrayed shopping for fruits and vegetables or preparing fruits and vegetables. When we show people mock news reports with these images, we find that viewing the stereotypical images on the left worsens public attitudes. People are more likely to have weight bias. They view individuals with higher weight as being more lazy. It increases their dislike of people with higher weight, and they want more social distance from them. But in contrast, when people see the same individuals portrayed in a non-stigmatizing images like those on the right, this improves public attitudes. It reduces weight bias, and participants in our studies express a clear preference for these more respectful images. And the reality is that we don't typically see respectful images of people with larger body sizes. And an important part of efforts to reduce stigma in communication is to make sure that any images of people that accompany key messages are ones that are respectful. So to help address this problem, the Rudd Center created a media gallery, kind of an image bank, containing hundreds of respectful images and B-roll video clips of people with higher weight. And we made these accessible and free to the public, and especially to the press. And in addition to our gallery, other national organizations have also created free galleries since then as well, including the World Obesity Federation, Obesity Canada, the Obesity Action Coalition. And I encourage you to take a look at their free galleries and to use these images in your own educational materials or training or presentations as a way to reduce stigma in health communication. Now, we know that communication that promotes healthy eating and healthy weight are important to support people in their journey to achieve a healthy body weight. So it's important to consider these issues of language and the use of images and really try to apply this to health messages that you might be trying to disseminate. And it can be helpful to take a step back and to consider the questions: when is it appropriate to communicate about weight, and when is it unnecessary or inappropriate? And how can you communicate the importance of healthy eating and healthy weight without triggering stigma? And how can you communicate in ways that are supportive to people of all body sizes? All right, quickly moving on from communication, the third clinical recommendation from our policy statement really involves considering the issue of weight stigma in the context of behavior change counseling. So we can help reduce weight stigma by really emphasizing patient-centered and empathic approaches when we're talking about weight-related health, and use approaches like motivational interviewing techniques that can really help empower and support patients to make health behavior changes. It's also very helpful to engage patients collaboratively and team decision-making about specific weight-related health goals for them. And I'm not going to spend more time on this here, as I'm sure that the clinicians and medical students attending today are very well versed in these approaches, but simply to say that we do need to make sure we are using these approaches as one of our tools to reduce weight stigma. And that supportive language is very key here as well, because too often patients are feeling blamed and shamed about their weight when they leave a medical appointment, and we want them to be feeling supported in making health behavior changes. And then finally, the fourth clinical recommendation has to do with addressing weight stigma in the physical clinical office setting. So we need to be mindful of the needs of patients with diverse body sizes, and we want to create a welcoming office environment that really facilitates their mobilization and their independence. there are fairly straightforward steps that can be taken to ensure that the clinical setting is one that is supportive and welcoming to patients of different body sizes. We actually have a checklist for this purpose that's available on our website. And essentially, it involves things like ensuring that equipment like beds and wheelchairs and exam tables have proper stability and weight capacity, that we use correctly sized medical instruments and supplies like blood pressure cuffs and robes, that there are well-configured doorways and hallways and restrooms that patients of different body sizes can easily be mobile in, and that we have a waiting room with a variety of sturdy, armless seating options. And speaking of the waiting room, and also thinking about what kinds of reading materials are available for patients. Are they things like fashion magazines that emphasize societal ideals of thinness and physical appearance? Or do you have reading materials that maybe don't emphasize weight or portray people of diverse body sizes? Now, as part of our work to reduce weight stigma in healthcare, we've done research with people who have higher weight to really ask them what kinds of changes they think would help to reduce stigma in healthcare. And a study I've highlighted here, we had participants, these were adults with high BMI, and we essentially gave them a list of about 25 different stigma reduction strategies. And we had them rate how important they thought these strategies are to help reduce stigma and how impactful they thought they would be. And as you can see here, about 90% felt that it's very important to implement education and sensitivity training for healthcare providers on weight stigma. And they also think that this topic should be addressed in medical school curriculum. And they also would like weight loss programs to offer supportive services to help them cope with weight stigma. We've done similar studies like this with healthcare professionals, and we also see that there is almost universal consensus among healthcare providers that sensitivity training is needed to prevent and reduce weight stigma in clinical practice. And there are some free educational resources that we've developed to really help healthcare providers have more supportive and productive conversations with patients about weight-related health. These and other educational resources are available on the Rudd Center's website, and they include things like informational slides and handouts and training webinars and educational videos about weight bias, really talking about how it affects patients and strategies for improving patient care. And then collectively, the evidence that I've summarized today, I think really underscores why it's important to consider weight stigma in the context of patient care. We really can't provide effective preventive care or treatment if we're not also recognizing and addressing the negative impact of stigma on health behaviors and outcomes. And optimistically, we are seeing increasing recognition by the medical community of the importance of addressing this problem. In March of 2020, Nature Medicine published an international pledge and consensus statement by the medical community to address weight stigma. It was signed by more than 100 medical and scientific organizations worldwide. And so we're really seeing increased awareness that stigma about weight must be addressed, and that the medical community really plays a central role in these efforts. So I think there are a lot of opportunities for health professionals to really help prevent the harms of weight stigma in clinical care. We can certainly increase awareness amongst ourselves and our colleagues about weight stigma and its harmful health consequences. We can practice and implement sensitive communication. We can engage in clinical strategies that support patients in their health behavior change, and we can really advocate to help create a more supportive healthcare environment for people of all body sizes. So I'm going to stop there so that we have time for questions and discussion. I'd like to thank you for your time and attention today. And I would be pleased to distribute the PDF of my slides that looked a lot cleaner when I uploaded it than the one that I just saw in front of me. So I'm pleased to share that with folks if it's of interest.
Thank you. Thank you, Rebecca, so much. Well, as far as the slides, you explained them so well that I managed at least to figure out what they were saying.
They were even in a different color for me, so it was very shocking as I was going through the slides.
It's the magic of technology. So I definitely, on behalf of Lydia and I, want to thank you so much. Lydia and I are going to ask we have a lot of questions from the audience, and we have some questions ourselves, so we're going to go back and forth. I do want to say that in a very profound way, from an ethics perspective, if the aim of medicine and the doctor-patient relationship is to help a patient be healthier, you have given us some very practical comments and practical ideas on how to do that go against, right, all the things we have been doing. And so it's definitely will be a learning curve, I think, for most medical professionals to move away from we've actually been making the problem worse all along. And so that's one of the sort of most shocking things about, I think, what you have to say. So one of our questions from the audience is, and I'm going to combine this with another question too, but if obesity describes a certain BMI, not a health condition, should we stop talking about it as if it were a disease? And would talking about blood sugar, cardiac health, et cetera, be more meaningful? And I'll tack on to that, as you actually educated me to this, that the AMA has determined obesity to be a disease. So which is it? How should our medical students be thinking about this, and how should they be talking to patients?
Yeah, so I think there's a couple of important issues to kind of unpack there. One is the issue of BMI and how BMI is the common metric of determining obesity. And there is increasing recognition and I think increasing viewpoints that BMI on its own is a limited metric when it comes to determining health. And that's only when it's used in conjunction with other metrics and health indices do we have a more accurate and comprehensive indication of a person's health. So BMI itself has come under increasing scrutiny when it's used on its own. It doesn't take into account a lot of different factors that we need to consider, whether it's nutrition or eating patterns or sleep or physical activity or stress or substance use or blood sugar or cholesterol. There's all these different factors that need to be considered. So that's one piece of this equation that is starting to get more attention. The other is the disease classification. And again, I'm a psychologist, I'm not a medical professional, but I certainly can talk to you a little bit about implications of this for stigma. And so when the disease classification came out in 2013, there were some people who thought that this will really help reduce weight stigma because it really takes away the personal blame, the personal responsibility. There were others who felt the opposite, that, hey, well, I'm not a diseased person. I have a BMI of 30, but I'm engaging in physical activity. I'm in good health. I don't have a disease. So there were really two different viewpoints. And from my perspective, this is an empirical question to study. So we studied it, and we took a general population sample of adults, and we asked them, we talked about the different viewpoints of this disease and what they thought in terms of stigma. And it was interesting that people kind of fell in one of three different camps. About a third of people thought this will be really helpful to reduce stigma. It will remove the blame. A third of people thought, no, this is going to increase stigma because it's going to label people as diseased who are not diseased necessarily. And then a third of people were kind of like, I don't really know what it's going to do. I think it could go either way. And so, since that time, I think there's much more awareness of the disease classification in the medical community than there is in the general population. There has been a little bit of research done in the medical community, and it does appear that the disease classification may be helping to temper and reduce weight bias among medical professionals, but there still is not very much work that has been done in this area. So I think there's still a lot we need to learn.
Thanks, Rebecca. Dr. Poole, I have a sort of related question. You had mentioned that weight discrimination has been associated with increased CRP, blood pressure, cortisol, and hemoglobin A1C. And we also know that those are all markers of stress in general. So I think I've been thinking throughout your talk a little bit about the chicken and the egg. And I wonder if you can parse that out for us a little bit more. Is this both, and is it, I mean, can we control for stress, life stress in general, to try to get at whether it is weight stigma that's leading to these things? I wonder if you could kind of clarify that for us.
Yeah, so the evidence looking at physiological stress has been studied in a couple of ways. Some are kind of prospective observational studies, and other are experimental studies. And I'll share one of our own experimental studies with you that looked at how just being exposed to stigma in the media actually increased physiological stress in terms of cortisol reactivity. So we brought women into the lab, and we randomly assigned them to view one of two videos. One video was a 10-minute video containing clips of popular TV shows and films in which women were being stigmatized and made fun of or shamed about their weight. In the other condition, women watched a neutral video containing things like insurance commercials and nature scenes, things completely unrelated to weight. After the woman had watched either one of these videos in whichever condition she was in, we brought her into another room in which there were some surveys to complete on a table. And on that table were 3 bowls of pre-weighed candy. And we said, these are just left over from another study. Take your time in filling out the surveys. If you want any of the leftover candy, go ahead. After she had left the room, we weighed the bowls again, and we looked at how much food was consumed. And what we found is that women ate 3 times as many calories from those bowls of candy after they watched the stigmatizing video compared to the neutral video. We then replicated this experiment, but measured their salivary cortisol levels before and after watching either one of these videos. And we found that stigmatizing video led to significantly increased reactivity of cortisol compared to those who watched the neutral video. And this was true for women across body sizes. So it tells us that women, even if they don't have a higher weight themselves, when they are exposed to even seeing weight stigma in the media, it is inducing physiological stress. And those are the kinds of experimental studies that have been done. There are lots of other ones. I'm just mentioning a couple of our own, but there are different ways that this has been examined. And we see that it really is stressful for people, across different body sizes.
That's fascinating. This is a question. There's long been a personal responsibility undercurrent to medicine in the United States, which tends towards a specific focus on weight and body size, substance use, and more recently, anxiety management. Do you think it's possible to minimize weight discrimination and stigma within this overarching personal responsibility mode of health, or would we have to rethink everything entirely? What kind of policies could we institute to go against such a strong, it is basic to American values, which is that with personal responsibility. What does that mean in this context?
Yeah, so there's 2 important issues here. One is how important and how big of a role does this personal responsibility frame play? And just as you started to talk about with American values, one contributor to weight stigma that runs really deep are American values and ideologies of individualism and personal responsibility for achieving success. The idea that personal effort and hard work lead to success, and if failure occurs, it's because you didn't work hard enough. And those deeply rooted ideologies are certainly strongly related to how people feel about different stigmatized groups in our society. And people with stronger beliefs in these ways are more likely to blame people for their stigmatized condition. And this is especially true with weight. So the view is that if a person has higher weight, it's because they didn't try hard enough to lose weight, and that their lack of effort justifies stigma towards them. We also see this in multicultural research, which has found that levels of weight bias tend to be higher in individualistic cultures that place a higher value on things like thinness and personal effort for weight compared to more collectivist cultures. And so this kind of ideology is an important piece of it, and it is a very pervasive frame in the society we live in. And so the second piece of your question said, well, are there policies? What do we do? How can we address this? Can we change the personal responsibility frame? That is a really lofty goal, I think. It's at the center of a lot of the messages that we see and that permeate throughout the media. But from the policy end, I can tell you there is policy strategy that is kind of in the works and has been for some time. So just as a brief synopsis, when it comes to the legal landscape of weight discrimination, currently it's legal to discriminate against people based on their body size almost everywhere in the US, with the exception of Michigan, a handful of cities across the country who have passed anti-discrimination laws that include weight. The vast majority of this country has no legal recourse or legal protection for people if they've been discriminated against because of their weight. So without those policies, that really continues to send a message that weight-based inequities, mistreatment, that this is acceptable. We've been doing research in this area for about a decade now, and our studies have been tracking public support for different kinds of policies that could be passed to address weight discrimination. And we're actually seeing substantial public support, primarily for 2 different types of policies that could be implemented. The first is having states amend their civil rights laws to add body weight and body size as a protected category alongside characteristics like sex, race, religion, sexual orientation, etc. This is actually what Michigan did back in the 1970s. So they've had their law for many years. And it's what other states like Massachusetts is trying to do right now. They've been trying to pass a law like this for a number of years. The second approach is really honing in on settings where weight discrimination is very common, like employment settings, to really make it illegal for employers to refuse to hire someone or fire someone or assign them lower salaries because of their weight. And we also see substantial public support for those kinds of laws. So both in terms of amending civil rights and including weight for more targeted laws to address employment-based weight discrimination. The vast majority of Americans in our studies, these are national studies, national samples, support these measures. And I think that starts to suggest that people really are viewing policy as an appropriate remedy to potentially try to help address this problem.
That's great. A common refrain in medical ethics circles is what is legal is not necessarily ethical, and what is ethical is not necessarily legal. And here it seems like what is ethical, that is anti-discrimination policies, is not legal in most jurisdictions in the United States, which is really quite interesting. I wanted to press in, kind of combining a couple of questions on, you gave us some really helpful language about talking about unhealthy weight as opposed to morbid obesity as a term or other terms that could contribute to stigma. There is a question about why refer to weight at all. Is that even the right way to talk about it? And then another question related to talking about behavioral changes such as exercise and healthy eating. Should that be a physician or a clinician's focus rather than weight as a metric itself?
Yeah, and that was something that I was alluding to in the talk, which is really trying to get folks to consider in their clinical practice, do I need to talk about weight today? Is it medically necessary? And again, I think sometimes the answer might be yes, but a lot of times it's no. And so I think it's thinking through then, what are the specific health behaviors? What are the specific health indices that we want to focus on? A lot of times there may be a provider who says, I really want this patient to lose 50 pounds. That's not a behavioral goal. That's not something that the patient necessarily even has any control over. So instead of focusing on goals related to a number on a scale, let's focus goals on measurable health behavioral changes, like replacing sugary drinks with water, like increasing physical activity to 60 minutes, to increasing fruits and vegetables and reducing portion sizes. Those are very specific, measurable, concrete goals that patients can engage in across body sizes, right? We want those goals to be for everybody. I think it's important to highlight that there are many people in thinner bodies who are not necessarily healthy, and we have to be careful about making assumptions that thinness is equated to health. And so really, I think challenging this idea of weight, it's not that it's never relevant. I think there are times where weight-related health is relevant, but making the default assumption one that doesn't always assume that the go-to conversation needs to be weight. I think that is important. I think you had a second part of your question, and now I'm just not remembering what the second part
You
was.
combined them beautifully.
Okay.
Thank you. Yeah, thank you.
I wanted to go back to also the role of physicians. And I wonder if there's been studies looking at discrimination on a very sort of concrete level, like decreased, you mentioned some things, shorter time, appointment times, but how about even referrals for specific interventions, or where, in fact, if maybe some of the poorer outcomes we see are actually due to the lack of medical care or the different medical care that those patients receive from physicians, and what that literature might be saying.
So far, most of this research is coming from patient perspectives rather than things like medical records. And that makes it hard to determine the prevalence. We have patients commonly saying in studies that they're being denied medical procedures because of their weight, or until they lose a certain amount of weight. Is that a medically appropriate decision? We don't know, because we don't have those links to the records. The other issue is documentation, and whether body weight is even being recorded as a reason for some of these medical decisions. And oftentimes it's not. So it's a very messy, difficult thing to try to get clear indication of how often this is happening and in what ways. Where we are seeing more of the provider reported studies is focusing on the kinds of things that I mentioned, like how much time are they spending in appointments, how much respect they have for their patients of different BMI levels, how frequently they intervene and provide health education. Those are the kinds of more observational outcomes that have been studied, watching, observing patient-provider interactions. But we really need to get into those medical records to look at some of these other procedural kinds of outcomes.
I'm a primary care doctor, and I've taken care of many patients who've really struggled with healthy weight over the years. And I've heard from many of them that they had never had a primary care doctor examine them before they came to me, that the physical exam just wasn't being performed. So that might be an easy thing to look at, because the physical exam is sort of a long amount of text that ends up in a note. And then I just am also thinking of one of these questions here in the chat about referrals to nutrition, or I could even imagine referrals to bariatric surgery would be other ways to quickly review records to see the extent to which weight is addressed, especially by primary care doctors. But I wonder if you could comment on this. I don't know if you have the question specifically from the audience is, what about doctors being encouraged to refer to dietitians who are better trained to discuss eating habits with patients? I suppose one question I have based on that question is, are dietitians always giving the kind of advice that you as a researcher in this area would hope for? Yeah, that was my my suspicion.
There is levels of weight bias are very high in dietitians as well. And we really see this again across different medical health professional specialties, and dietitians are not immune to this either. It's something that's not included in training. And if we think about it, they really are focusing their interventions on personal behavior. So it's easy for the bias to creep in, and that's also where a lot of sensitivity training and education is needed. And I actually often speak to classes of dietitians for this reason.
Can I just quickly follow up on that, Barbara?
Mm-hmm.
What about group classes? There is some data in other on other subjects in other fields where group classes are very beneficial for patients because of the sort of camaraderie that develops and the support and the accountability. Have you any research on that?
Yeah, and actually, as a clinical psychologist, I used to run many groups of patients with larger bodies who were struggling with binge eating or weight management, and the group setting actually was very powerful. One of the reasons is because for the first time, they were learning that they were not the only ones who were experiencing shame and stigma, and it was a very supportive way to have that social and some emotional support from people who are going through the same thing. I think that really did help improve levels of psychological distress. It reduced a lot of anxiety and depression around it. In terms of eating behaviors, that social support is really important too. And so I think the group context is beneficial, both for those healthy behavioral changes as well as for psychological functioning.
At the very beginning, and so Lydia and I are both parents. The very beginning of your talk, you talked about the effect of parental stigma on their own children. And I'm sure, as a parent myself, that there's not an intention, of course, to make their children feel worse or be worse or feel less about themselves. So I must assume it's unintentional on their part, but I wondered if you could speak more about that and how we could support parents better.
Yeah, so this is a really challenging piece of this work. So, body weight is a very sensitive, very emotionally charged topic, especially for children and teens. Their bodies are changing as they become more aware of vulnerable societal messages about weight and ideals of thinness. There's a lot going on. A lot of parents talk to their kids about their weight. About 2/3 of parents engage in what we call weight talk with their child, which essentially means making comments about their child's weight. And this can take different forms. Sometimes it might be encouraging their child to diet. It can involve insults or teasing their child about weight. It could be the kinds of comments even that parents make about their own weight in front of their child. And typically, the more that parents talk about weight to their child, the more likely that the child is to have worse body image, unhealthy or disordered eating behaviors, depressive symptoms, low self-esteem. And so, oftentimes, parents do have positive intentions. Parents are worried about their child's body weight, but those concerns get expressed as criticism, as judgment or blame. or as teasing. And this is really problematic. So, we've done a lot of research, quite in the last year, looking at how parents and adolescents in particular communicate about their weight. We're seeing a lot of barriers. Most teens are saying that they never want to talk about this with their parents because it makes them feel upset and embarrassed. And, at the same time, we see parents saying, well, but I want to talk about it so that my child has a positive body image and I want to help protect their self-esteem. So clearly there's a disconnect. And, I think what all parents want their children to be healthy. This is more likely to happen if parents focus more on their actions rather than their words, and they instead model healthy behaviors that they want to see their children engaging in. And they create a home environment where children can easily make healthy choices, and they promote healthy behaviors that everybody can engage in as a family, rather than just singling out a child who they are concerned about their weight. So rather than kind of focusing the conversations on the child's appearance or child's weight, we really recommend that parents keep those conversations focused on health as much as possible, and focusing on health behaviors that everybody can engage in together. I think it's also really helpful for parents to talk about how healthy behaviors translate in terms of their child's concentration and abilities and energy, and rather than just making it all about the number on the scale or physical appearance. So it's a challenging time for parents, for sure. And I think really trying to shift those conversations is really needed.
And I'll follow up with, did you see in the chat, Lydia, there's a
Yeah.
question following that up, which I think is really interesting.
Yes.
What should a parent do if kids come home with negative statements about weight, and meaning in particular, how do you make sure your kid isn't the one doing the stigmatizing?
Yeah. So parents have a really important opportunity here, because kids are being bombarded with so many messages that are, again, promoting those ideals of thinness, that a person's value is based on what they look like. And as parents, we have like one opportunity each. I'm a parent too, of what message we can tell our kids to try to counteract some of that negative messaging. So again, we have an opportunity to model respect of people across different body sizes, to help children understand that teasing regarding physical appearance or body weight is just as unacceptable as teasing or bullying based on race or sexual orientation. To really elevate this as an issue that is, unacceptable and an injustice for many people. Parents can also point out examples of people that people in your community, celebrities, to your child who are examples of people with larger bodies that challenge negative stereotypes that we see around us all the time. Because too often, social media is just a place where kids are going and they're seeing a lot of fat shaming occurring and a lot of weight bias, but they're not seeing those other messages. So I think those are some things we can do. But certainly, this brings us to an issue of just how bullying is being addressed in schools. Weight-based bullying is often not on the radar in school-based policies, even though we know that it's one of the most common reasons that kids are bullied. So it's also, trying to get it on the radar of educators, and trying to make sure that the language of school-based anti-bullying policies includes things like body weight that kids are at risk of experiencing bullying for. So there are a lot of levels there, but I think as parents, we can do, a lot with our messaging and modeling of respect for people of diverse body sizes.
I'm so glad we took that pivot. And maybe I'll just follow up with the last question from the audience in our last couple of minutes here. Do you think that fat activism, which is the language put forth by the questioner, could play a beneficial role in reducing weight stigma and or make public health approaches to the obesity epidemic less harmful? And I would add, could it also make the obesity epidemic more of a problem if fat activism is more widespread?
Yeah, that's a really big question. So, I think what's important is that there are multiple groups who are invested in addressing weight stigma and discrimination. We have the medical community invested, the obesity field invested, public health, and we also have activist groups like Health at Every Size and the National Association for the Advancement of Fat Acceptance. There are some very diverse and polarizing views across these different groups when it comes to things like obesity. However, there is a common goal across these groups, which is to address weight discrimination. And I think, we're at a time right now where there's a lot of polarization and not a whole lot of listening, but I think that there is some common ground here where these groups can work together to actually do things like help get push policies forward to get legislation passed. And that's where I hope those efforts of these different groups can kind of come together.
Well, we have run out of time, but I want to say this has been absolutely amazing. I think that it's been both interesting, educational. I think we all, if we listened carefully, might actually be able to take better care of our patients and fulfill one of your slides said that people hoped that this would be included in medical school curriculums and other healthcare provider trainings. And so I feel like we're also fulfilling some of that here. So I want to thank our speaker so much for your time. She really stuck with us because we've been planning this for a little while, and I'm just so glad that she was able to do this with us. I want to thank Lydia in the Center for Medical Ethics, as always, for their wonderful support and also their partnership in this. And I want to thank Robert Klitzman, who is my boss in the Masters of Bioethics. Samir Lada is our deputy director, and Athena, who is our do everything. Athena and Charlene from the center both make all of these things work as smoothly as they do, along with our tech team, who is amazing. So thank you to all. Thank you and to our audience who showed up. We're really grateful that you came, and we hope you come to the next one. And if you just wait a moment, those slides will come up and tell you what the next ones are. So please come and attend. You'll see those slides in just a second, and we hope to see you next time.